Okay, so welcome everybody. This is part 2 of the first of 4 sessions on medical billing. This is the Gold Star Medical Billing Boot Camp. This is part 1, and we had the first half of this webinar on Monday of this past week. And during that webinar, we just really did an overview of what the functions of a medical billing office are. We talked a little bit about how our company, Gold Star Medical, works with both billers and clients to bring them together to be able to help people who are interested in the medical billing field get jobs as medical billers, how you work from home, and some of the intricacies of working from home as a medical biller, some of the challenges that you might face working from home with respect to your schedule and so on and so forth. And then we began to kind of delve into health insurance in general, and we went through a little class called the Basics of Health Insurance. And in the Basics of Health Insurance, we talked about the different types of insurance plans that you may be encountering as a medical biller, and how benefit structures are organized for patient insurance benefits. We also talked a little bit about the importance of patient collections with respect to insurance, because nowadays the insurance piece of the pie is much smaller than it used to be, even 10, 15, 20 years ago. And so all of that was covered in the first half of this class, again, which was on Monday. I have recorded that class, so if you missed it and you have not received the link for that webinar yet, by all means, send me an email. Again, my email is goldstarmedical@msn.com, or you can go directly to YouTube and you can look up my channel. If you just do a search for Gold Star Medical, all the webinars that I have recorded are on there, and you can go directly to that webinar, and it is recorded and loaded up on YouTube. If not, just send me an email and I will get you the recording of the first half of this class, so that you don't feel like you're kind of behind. You don't have to worry, because the material that we covered in the first half of the class is really not material that this class builds on. This is all sort of independent vignettes of information that you need to know as a medical biller. And so today, what our goal is to get through is going to be to have a fairly lengthy discussion, relatively speaking, about Medicare, about the Medicare program and how the Medicare program is structured, about the different types of Medicare, the different parts of Medicare, and we're also going to talk about how the coding that we spent a lot of time on over the last month or so applies to medical billing. And so there's going to be a short presentation on the basics of coding, which if you have been taking the full boot camp, which was the coding portion, the first half of the camp was the coding portion, and now we're in the billing portion. This will be quite a bit of a review for you, but it won't be very long. But one of the things I want to do is take that whole coding portion and show you how it applies to billing. Because right now, you know, if you took the coding portion, all you really know is these are codes, but may not have a complete understanding of how those codes are used with respect to getting reimbursed by the insurance carriers. So, without further ado, I am, right now I do have everybody unmuted, so you can speak. If I hear that there's a lot of background noise, I may go ahead and mute everybody, and then at a certain stopping point, unmute everyone for questions. But if you do have any questions that you would like to type into the chat box, We will have stopping points throughout the presentation tonight to discuss questions that you might have. And if you're thinking about something and you don't want to forget it, and you're either muted or I'm in the middle of something and I can't answer that question, you can put it in the chat box and then we will address it at an appropriate stopping time. So let's go ahead and get started. And the first part of this class, like I said, we're going to be talking about Medicare. And Medicare is the largest insurer of individuals in the United States by far. Medicare insures more people than the three largest commercial health care plans combined. And so the first thing that I'm going to do with you today is I'm going to actually show you a little video. It's just a 5-minute video on what is Medicare. It kind of gives an overview of the Medicare program, and then what we're going to do is we're going to actually get on the CMS.gov website, which CMS stands for the Centers for Medicare and Medicaid Services, and I'm going to show you all of the educational tools you have at your disposal as a medical biller when it comes to billing and coding for Medicare services. And so we're going to talk quite a bit about Medicare. So without further ado, I am going to go ahead and get started on the video called What is Medicare? And I encourage you to sit back and listen to it. You should have some handouts that you received when you received your invitation with some basic notes about the Medicare program. Certainly use those. You can write in the margins and then add anything you want to it. So here we go. What is Medicare?
The Medicare program is the largest health insurance program in the United States. If you're a healthcare professional, chances are some of your patients will have Medicare coverage of some kind. But what is Medicare? This video will provide you with a high-level overview of the Medicare program. It includes basic information about Medicare's various parts and who it covers. If you're looking for more detailed information beyond this introductory level video, please visit the Medicare Learning Network on the CMS website at cms.gov. Then click on Outreach and Education, and once there, click on MLN Products. The following types of patients can enroll in one or more parts of the program: individuals aged 65 and older, individuals under the age of 65 who have certain disabilities, and individuals with end-stage renal disease, or ESRD. The government agency that administers these programs is called the Centers for Medicare and Medicaid Services, or CMS. CMS also works with several organizations to help them administer the program. This includes Medicare Administrative Contractors, or MACs, which process claims for Medicare Parts A and B, Medicare Advantage plans, which offer additional coverage beyond Parts A and B, and private drug plans that cover some drugs that Parts A and B do not. The Medicare program consists of several parts: Medicare Part A, Medicare Part B, Medicare Part C, and Medicare Part D. Let's take a look at what each of these parts covers. We often call Medicare Part A hospital insurance. Part A helps pay for inpatient hospital care, inpatient care in a skilled nursing facility, SNF, after a covered hospital stay, some home health care, and hospice care. Please note, for each service Medicare covers, your patients must meet coverage and eligibility requirements. This applies for all parts of the Medicare program. Medicare Part B, often called medical insurance, helps pay for several additional services, including physician services, some preventive services, home health for patients without Part A, ambulance, laboratory and diagnostic services, surgical supplies, durable medical equipment, prosthetics, orthotics, and supplies, hospital outpatient services, and services from a practitioner with a limited license, including audiologists, certified nurse midwives, certified registered nurse anesthetists, clinical nurse specialists, clinical psychologists, clinical social workers, independently practicing occupational therapists, independently practicing physical therapists, independently practicing speech-language pathologists, nurse practitioners, and physician assistants. People often refer to the combination of Medicare Part A and Part B as Original Medicare or fee-for-service. Note, if you are a healthcare professional and you want to accept Medicare payment, you have to enroll in the program. To enroll in Medicare, visit the CMS website at cms.gov, click on Medicare, and scroll down to Provider Enrollment for more information. Medicare Part C, which we often call Medicare Advantage or MA, is another option Medicare beneficiaries can choose. MA plans are private insurance companies Medicare approves to offer benefits to our beneficiaries. MA plans must cover all services that Medicare Part A and Part B cover, with the exception of hospice care. In addition, MA plans may offer additional benefits that traditional Medicare does not pay for. Note, if you provide services to a beneficiary who has enrolled in an MA plan and you do not have a contract with that plan, you should still send your bill to that plan. However, you should inform the beneficiary that he or she may be responsible for all the charges. Medicare Part D is the Medicare prescription drug benefit. Beneficiaries may choose to enroll in one of these plans since they cover a variety of drugs that Original Medicare does not. Medicare approves insurance plans or private companies to provide these services. Each plan can vary in cost and what they cover. This concludes our high-level introduction to Medicare. We hope you found this helpful. If you want to learn more, please visit the Medicare Learning Network at cms.gov, click on Outreach and Education, and once there, click on MLN Publications.
Okay, so that just gives you a little bit of an overview of the Medicare program. As you see, CMS covers 100 million people, and so as a result, Medicare is the largest health insurer in the country. And what the lady who was the narrator for the Medicare introduction video was discussing with you was this cms.gov website, and as a medical biller, this is definitely going to be one of those websites that you're going to want to bookmark and have very handy at all times. Medicare is not only the largest insurer, but they also have the most prolific amount of education tools and instructional tools for you as a medical biller. There's really nothing that you can't find in the Medicare website, on the Medicare website, as it pertains to Medicare patients. So I really, really want to encourage you to have this website bookmarked. And one of the places you're going to spend quite a lot of time is you're going to spend a lot of time in the Outreach and Education tab. So I just want to click on that for you. And I'm going to encourage you all, you may want to write this down. We'll go slow enough to where you can write this down, but I want to encourage all of you to set up an account with Medicare to get access to their training videos and their training webinars. And so if you go to this www.cms.gov website, from there you're going to reach the cms.gov website, which is the home page. Okay, and let me go back to the home page for you so that I can take you there with me. So here's the cms.gov website, and then you have the orange boxes across the top. The very last one to the far right is called Outreach and Education. If you were to click on that, it will then take you to a section that says Learn. And right below it, it says, there's a link that says Get Training. Okay? And so if you click on that Get Training link, it will give you training links to a number of areas within Medicare. Okay? But the main one that you would want to have access to is the Medicare Learning Network, which is the one right up at the top of the Get Training section of the Medicare website. So if you click on the Medicare Learning Network link, it will take you to a page that show that, of course, the home page. You have publications and multimedia. You have newsletters and social media, events and training, continuing education credits, and provider compliance. Under the events and training section, you see a link called web-based training. And if you were to click on web-based training, it would give you an opportunity for you to log in to see all of the different courses. Now, some of the courses are video and some of the courses are audio. Some of them have webinars with them. Some of them are audio with narration, and some of them are just self-paced courses that you go through yourself, okay? And so how you get your training, and you can receive a training certificate for all the training that is in this Medicare website. For those of you who may be taking this class and maybe you're not going to be moving forward with a career as an at-home medical biller, and you're wanting to get a job working in a hospital billing office or a doctor's billing office, for you to take the initiative to go through this training and enroll in these different courses and then receive the certificates from Medicare that you took this training will really add a lot of richness to your resume. So I definitely want to recommend that on your own pace you get as much training as you possibly can. And you'll notice that under the web-based training it talks about some of the different general Medicare program information courses, coding, fraud and abuse, home health, medical payment policy, office management, provider compliance, and so on and so forth. But in order for you to have access to these courses, you need to be able to log in. And so you would click where you see the link that says WBT courses login for course descriptions. So this is where you would log in to the web-based training section. And of course, I have an account that I use to log in to access these training courses. But if you do not have one, then there's an option here on this page for you to create an account. So you can click on Create Account. And this is where you would put in a unique login ID that you would want and a password. Confirm the password. You would put in your name, first and last. Everything with an asterisk is required, okay? Now, it's going to ask you for healthcare provider, healthcare facility type, and association. What you would want to do is you would want to click the drop-down menu, okay? And you can click on Other. You can click on Office Manager. You could click on Student if you wanted to. You just need to click on whatever facility type it is, okay? Customer service representative, whatever you would want to do. Front office staff, facilitator, healthcare administrator, healthcare researcher. So you don't have to be a doctor or an attorney. You just have to let them know what type of healthcare provider you are. Then you would click on the type of healthcare facility type, and the type of healthcare facility type would be medical billing organization. So you can click on medical billing organization, or you can even click on Other if you wanted to. And then under the association, you could click on Other or None. Then you have your address, okay? And there's going to be a section, this is going to be your address, city, state, zip, postal code, work phone. And then in the second section it says organization, and you'll notice that there is an asterisk, so you have to choose something. So if you click on Select, it gives you an option to search, okay? And this would be the organization that you would choose, the MLN Learners Domain organization, okay? Then you would save that. I'm just going to cancel out of it, okay? And then, of course, your region, your time zone, and if you do need accessibility, you can enable accessibility, and then you would create your account, okay? And this would allow you access to all of the web-based training, audios and videos that are available in the Medicare network. So with that said, let's go ahead and I already have an account, so now, and I have already logged in, and so what we're going to be doing is we're going to be doing some training about the Medicare program to give you an overall kind of expand on that little 5-minute video and give a lot more detail to what was discussed during that video. And one of the training courses is called The World of Medicare. And basically in this course description, this is where we're going to learn about the fundamentals of the Medicare. I want to get my highlighter here. We're going to learn about the fundamentals of the Medicare program, Part A, B, C, and D. The beneficiary health options, eligibility and enrollment, and how Medigap and Medicaid work with the Medicare program. Okay, this activity is designed for healthcare professionals and administrative staff. So I'm going to go ahead and I guess I have to undo that. It's not going to let me go in. So hang on. I don't want my highlighter anymore. Okay. Get out of that, my highlighter. Okay, I'm out of my, no, I'm not out of my highlighter. Okay, here we go. So now I can resume my my exam. Erase everything. And we went through this with our class on Saturday, and they found it very, very informative. We're going to skip through the introduction and the pre-assessment. We're going to start right with Lesson 1, Medicare Essentials. It takes a little bit of time to load these, so I apologize. Here we go. Okay, so the lesson objectives for this particular section of our class tonight is to have a good basic understanding of the Medicare program, because you as a medical biller are going to be dealing with Medicare quite a bit. Medicare patients are the largest growing segment of insured patients in the United States. They continue to grow every year, more and more. We have more and more people entering the Medicare rolls. There are more and more people living longer, and so more people are on Medicare for longer periods of time. And so it's very important to know about Medicare and about the different parts of Medicare and how these programs work. So let's go ahead and get started. As the video mentioned, the Medicare program is the nation's largest health program, and it's very important that individuals and institutions who provide Medicare services have a broad understanding of how the program works so that you can identify Medicare benefits, accurately bill Medicare services, and provide care to people with Medicare. So let's talk about some of these Medicare basics. The Medicare program is a federal health insurance program for individuals age 65 and older, individuals under age 65 who have certain disabilities, and then any age person who has been determined to have end-stage renal disease. In order to qualify for end-stage renal disease, you must have chronic kidney disease or some disease that puts you on dialysis. The minute you go on dialysis, you are considered to, I mean, sometimes a person is put on dialysis to clean the blood, one time. But if you're put on regular dialysis, you're considered to have end-stage renal disease, which means you're probably on a list for a kidney transplant. And you would automatically be qualified for Medicare for that diagnosis only, unless, of course, you had Medicare as a person over age 65 or as somebody on disability. Medicare started in 1965, and there have been, throughout the years, there have been major additions and changes to the Medicare program. We're going to go through this timeline here and look at how the Medicare program has expanded over the years. So in 1965, the Social Security Act wrote Title 18, and this is when Medicare was established. Okay, I find that interesting because I just felt like always thought Medicare was around forever. You know, I mean, way before I was born, and it actually Medicare didn't start until a few years after I was born, and I just think that that's very interesting. Title 19, the next year, established Medicaid. Medicare was to provide health care insurance for aged persons. Medicaid would pay for medical assistance for certain individuals and families with low incomes and limited resources. Medicare was a responsibility of the Social Security Administration, while federal assistance to the state Medicaid programs was administered at that time by the Social and Rehabilitation Service, which was the SRS. The SSA and SRS were agencies within the Department of Health, Education, and Welfare. The Medicare program then began establishing health insurance coverage for persons aged 65 or older, and the program included Part A and Part B, which is also known as the original Medicare plan. So original Medicare is Medicare Part A and Medicare Part B. In 1972, Congress expanded the Medicare program to include certain disabled individuals and individuals who had ESRD and stage renal disease. So while Medicare was in force since 1966, it wasn't until 6 years later that they expanded it to include people on disability and people with ESRD. In 1977, the Healthcare Financing Administration, or HCFA, which is known as HCFA, was created under the Health, Education, and Welfare Department to effectively coordinate the Medicare and Medicaid program, which were the two largest healthcare programs in the United States. In 1980, Health, Education, and Welfare was divided out into the Department of Education and the Department of Health and Human Services. In 2001, HCFA was renamed the Centers for Medicare and Medicaid Services, or CMS. So CMS has been known by that acronym since 2001. Now, for some of us old-timers who have been involved in the medical billing field forever, for example, I have been doing medical billing since 1985, or 1982, I'm sorry, and 35 years. And so for many, many, many years, all the way up until 2001, a claim form was called a HCFA form. It was a Healthcare Financing Administration 1500 form, so it was called the HCFA 1500. And so I still will slip up from time to time and refer to a claim form as a HCFA form. So if through this billing boot camp you hear me do that, please pardon the ramblings of an old woman. It just has to do with the fact that I called it a HCFA form for so many years. I try not to anymore, and I have gotten better. Now the HCFA form is known as the CMS 1500 claim form instead of the HCFA 1500 claim form. In 1997, Medicare expanded again to add Medicare Part C. These were healthcare options created for people with Medicare. They were called at the time Medicare Plus Choice and generally replaced the earlier healthcare insurance options. So in other words, Medicare patients were given the option to use private insurance instead of their Medicare if those private insurance carriers would enroll under a Medicare contract. And then in 2000, 3 years later, The Medicare, Medicaid, and State Children's Health Insurance Program, or SHIP, Benefits Improvement and Protection Act, waived the 24-month waiting period before Medicare entitlement for persons with ALS or Lou Gehrig's disease and who were eligible for Social Security benefits. So basically, when Medicare expanded to allow people who are on Social Security disability Medicare benefits, they did so, but they had a 2-year waiting period. So you could get on SSID or Social Security individual disability benefits, but you still to this day cannot receive Medicare or be eligible for Medicare until you've been on Social Security for at least 24 months, or if you've been diagnosed with ALS. And that is the only diagnosis at this time that waives the 24-month waiting period for folks on disability. Now, if you have end-stage renal disease, no matter how old you are, you do not have to be on disability. You're eligible for Medicare benefits for ESRD. I went too far. Hold on. In 2003, the Medicare Prescription Drug Improvement and Modernization Act, or MMA, was signed into law, making Medicare more prevention-focused, offering more affordable health care, prescription drug coverage, expanded health plan options, improved health care access for rural Americans, and preventative health care service. As a result of the MMA, Medicare Part C is now known as the Medicare Advantage Plan, and the MMA also created Medicare Part D, which is the Medicare Prescription Drug Plan. So Medicare patients were not able to have their drugs paid for under Medicare Part B until 2003. And in 2006, the voluntary Medicare Prescription Drug Plan formally began. Medicare Improvements for Patient and Providers Act of 2008, or MIPA, was signed into law improving beneficiary benefits. MIPA affected mental health coverage under Medicare, improved coverage of preventative care services, implemented new rules regarding Medicare Advantage marketing, and improved Medicare supplemental coverage. And then finally, the Affordable Care Act, or what we know as Obamacare, included a series of Medicare reforms that generate savings for Medicare and strengthen the care Medicare beneficiaries received. This law provided new benefits and services that help keep beneficiaries healthy. Things like colonoscopy screenings, mammograms, annual wellness visits, annual well women visits with no out-of-pocket costs to the Medicare beneficiaries. Today, Medicare covers over 50 million Americans, and Medicaid covers over 50 million Americans. So between the two programs, over 100 million Americans are covered. So let's talk about, now that we have an idea of the timeline for Medicare, let's talk about the different parts of Medicare. So Medicare Part A is also known as hospital insurance, and this will help cover inpatient care in hospitals, inpatient stays in a skilled nursing facility, also known of as a SNF. That's not custodial or long-term care. Typically, inpatient stays in a SNF are limited to 60-day period. Hospice care services, so if a patient goes on hospice, they're eligible for Medicare Part A, and home health care services. Some individuals are automatically enrolled in Part A. Others apply to the program when they're eligible. Now, this is something not everybody knows. Most people are under the assumption that if as soon as you become age 65, you're automatically enrolled in Medicare Part A. But that's not necessarily true. In order to be eligible for Medicare Part A, you must have contributed at least 40 quarters of payroll deduction into the Medicare Part A program. So 40 quarters, 4 quarters per year is equal to 10 years. So number one is you will have had to have worked as an employee of a company that takes Medicare deductions on your behalf and submits them to Medicare as basically as your premium toward the Medicare Part A program. But if your company, for example, never sent in those deductions to Medicare, or didn't participate in that voluntary participation of Medicare Part A deductions, or if you were self-employed all your life, or if you are in certain other types of situations where you never reached 40 quarters of eligibility, you may not be eligible for Medicare Part A unless you apply and pay premiums on a monthly basis for Medicare Part A services. And so we'll talk about that a little bit later in this lesson, but it's not an automatic assumption that you're just going to be in Medicare Part A. You will have had to have contributed at least 40 quarters in order to be eligible for Part A. Part B is also known as medical insurance. Medicare Part B is voluntary, so when you retire, or if you go on disability and you have waited out that 2-year waiting period, at that point you're going to be given the option to buy Medicare Part B insurance, okay? You are going to have to pay a monthly premium for that. So the payroll deductions that you took over the years for Medicare did not include Medicare Part B. It was only for Medicare Part A or hospital insurance. Medicare Part B has a specific enrollment periods, an initial enrollment period and then subsequent enrollment periods, and only during the enrollment periods can you sign up for Medicare services. And once you're signed up, then it helps to cover physician services, outpatient care, certain preventative services, and other medical services that Part A doesn't cover. Part B is subject to coverage and limitations. Part A and B are also referred to, as we've mentioned before, as the original Medicare plan. Now we'll learn more about the original Medicare plan in Lesson 2. Part C, the Medicare Advantage or the MA plans, may provide Part A and B benefits, so they combine Part A and B. Many MA plans also include prescription drug coverage and may also include other supplemental benefits. So it's kind of all the plans rolled into one. Medicare Part D is a voluntary plan that helps cover prescription drug costs. So if you are a Medicare Part B patient, or you have a Medicare Part B patient, and that Medicare Part B is not going to cover prescription drugs, they would have to elect to voluntarily pay an additional premium for the Medicare prescription drug plan. Okay? And however, if you have Medicare Part C, more than likely Medicare, the prescription drug plan is going to be covered under your Medicare Part C. So here are the different choices you have. People with Medicare are called beneficiaries. We call them patients because that's what we're dealing with in the medical billing world. And so if I use the word patient or beneficiary, that's one and the same. So in most cases, this is what is going to happen if a patient chooses the original Medicare plan. If they choose the original Medicare plan and they choose to go that route, okay, they're going to be automatically enrolled in Medicare Part A, providing that they have contributed enough time into that program over their working years. They will elect to take Medicare Part B, which is a monthly premium. The Medicare Part A does not have monthly premiums if you're eligible. Medicare Part B will have a monthly premium. Now Medicare Part B, because it only covers a limited amount of doctor visits, most Medicare patients who have Medicare Part B will also purchase a Medigap policy or have some type of a supplemental policy through an employer, a union, maybe if they're a retired veteran, or they may have TRICARE or other coverage that pays after Medicare, okay? And that is called a Medigap policy because it's designed to gap the benefits. In other words, Medicare takes it so far, and then the Medigap will fill it in, okay? And then they would also more than likely purchase the Medicare prescription drug plan. Now, people who are on higher income, or who are in higher income levels, may choose not to purchase any of this. They may choose to have all of their outpatient visits, their medications, outpatient surgeries, and so on and so forth. They may choose to just pay for those out of their own pocket, and not even purchase Medicare Part B and only have Medicare Part A. And there are individuals who have only Medicare Part A. So it's very important, if you're working in a doctor's office, in a billing office, that when you look at a patient's Medicare card, that you're looking to see if they have Medicare Part A plus Medicare Part B. So this is the first track that they can go as far as if they decide to go with the original Medicare plan. Now, if they want to instead roll all of those plans into one, Medicare A, B, and prescription drug, they may choose to go with the Medicare Advantage plan, okay? And those are also referred to as Medicare Part C. Many of the plans will include Medicare prescription drug coverage. It's one of the ways that the Medicare Advantage plans try to stay competitive. And so the beneficiaries who have Medicare Advantage plans, however, will not be eligible for any type of Medigap coverage or supplemental coverage. So if you choose Medicare Advantage, then you would not have a Medicare supplement of any kind. And so this is where there's always a question that that is posed to me in classes like this, is if we have patients and they want to know which is the better plan, or you even, if you're listening to this, you may even be at a point in your life, or you may have parents who are at a point in their lives where you're trying to decide the route that you're going to go with respect to Medicare. And so one of the things you need to understand about the differences between the Medicare Original and then the Medicare Advantage plans is that Medicare Advantage plans are going to try to enroll you or entice you into that plan with promises of much lower premiums, the monthly premiums. So if you have to, for example, let's go back one slide. If you go with original Medicare, you're going to be paying a premium for Medicare Part B, you're going to be paying a premium for your Medigap, and you're going to be paying a premium for your prescription drug. And when you add all three of those together, it is probably going to be higher than a Medicare Advantage plan, okay? But if you go back and you give yourself full coverage like this, with a Medigap plan and a Medicare prescription drug plan, other than the Medicare prescription drug coinsurance amounts or copay amounts, you're pretty much going to not have any out-of-pocket costs for Medicare-approved services. As long as Medicare approves the services, if you're under original Medicare and you have a Medigap plan, your out-of-pocket costs on the back side of things are going to be much less. Your premiums on the front side are going to be higher than under the Medicare Advantage. The Medicare Advantage will have lower premiums, but you may have copay amounts and coinsurance amounts. There are very few Medicare Advantage plans that offer 100% coverage. So you're always going to have some type of a copay or a coinsurance. Medicare Advantage plans can be set up as PPOs or HMOs, and so they could be very, very restricting depending on the plan you choose. Some people on extremely limited incomes love these Medicare Advantage plans because their initial out-of-pocket costs are so low. However, what you'll find is that many Medicare Advantage patients will find themselves in a world of hurt if they have significant health problems that require those out-of-pocket costs to kick in. So those are the things to watch out for with the Medicare Advantage plans. And honestly, as a biller, or if you're listening to this and you're an office manager, or even if you're listening to this and you work at your front desk, and a patient asks you which one you should sign up for, your answer to them is, I cannot tell you that. All I can tell you is how the costs work. And then it would be up to them to choose whether they want to pay a little bit more for better coverage, or lower out-of-pocket costs. I wouldn't say better coverage because they all have to offer the same benefits. It's just how much the patient is going to have to pay if they utilize a Medicare Advantage plan. So when a person becomes eligible for Medicare, the first thing they're going to do is decide which track they're going to go. And they're going to choose either the original Medicare plan or a Medicare Advantage plan. If they choose original Medicare, then they would have Part A, and they can choose Part B, or they can go the track of the Medicare Advantage plan, which is Part C, which includes both A and B benefits. Now, if the patient chooses original Medicare, then they need to decide if they want the supplemental coverage. And if they do want the supplemental coverage, the only choice they have is to stay with original Medicare, which is Medicare Part A and B, and then they can choose to purchase a Medigap policy, which is a private supplemental policy that would help pay some of the health care costs that the original Medicare plan doesn't cover. Most of the time, these Medigap policies will cover for the Part B costs, which are the physician costs. A Medicare patient normally has a deductible of around $185 per year, and it goes up every year, so that's sort of just a rough estimate. And a Medigap policy will usually cover that deductible, plus once the deductible is met under Part B, then Medicare pays 80% of the allowable charges, and the Medicare patient would pay 20%. The Medigap policies are designed to gap that and cover that 20%. Some of the Medigap policies will pay the hospital deductibles as well. And so a hospital, even though Medicare Part A doesn't require you to pay any premiums, you do have a hospital deductible, and it's somewhere around $1,300 for the Medicare hospital deductible. So if you're hospitalized, you have to pay a deductible. If you have a Medigap plan and you have a decent one, it's going to cover that Medicare hospital deductible. And so you need to choose as a beneficiary whether you're going to choose that supplemental coverage or not. If you decide that you don't need supplemental coverage, then you could look more seriously at the Medicare Advantage plans. Beneficiaries who join an MA plan usually do not need and cannot purchase a Medigap policy, and so these are some of the things, again, that you have to be aware of when it comes to your beneficiary. If you go back after this lesson and after our webinar, and you go back and re-watch this video, okay, one of the things that you can do throughout these webinars are click the plus signs at the bottom of the webinar slide, and where you can get more detailed information about beneficiary coverage. I'm not going to go there right now, but that's something that you can do. And you would find that, right in this section here. Okay. The next choice that you would have if you're a beneficiary is, do you want a drug plan? And so again, if you have Medicare Part A and B, the original Medicare, then you would have to choose a drug plan or choose a Medicare Advantage plan that includes prescription drugs. Now, it does have an additional cost to the premium, and so if it doesn't include and if you do have a Medicare Advantage plan that you really like, that has really low premiums, you may want to just join a Medicare prescription drug plan separately. You can do that. You can't join a Medigap plan, but you can join a Medicare prescription drug plan if you have Medicare Advantage. Now, there are some beneficiaries who have limited incomes and resources who may be eligible for Medicaid as well as Medicare, and these people who have both Medicare and Medicaid are called dual eligibles. So for people with full Medicaid coverage, Medicaid supplements Medicare by covering services and supplies available under their state's Medicaid program. Limited Medicaid benefits are also available to pay for some of the out-of-pocket Medicare cost-sharing expenses for some of the other Medicare beneficiaries. Always remember that in the Medicare-Medicaid relationship, Medicare is always primary, Medicaid is always secondary. So, how do Medicare beneficiaries enroll? The Social Security Administration is responsible for enrolling most people in Medicare. The Railroad Retirement Board enrolls railroad retirees into Medicare. So there's a little special section of Medicare called Railroad Medicare that is only for railroad retirees. Okay, and if you ever wanted to find out, or for yourself or for a parent, where you stand with respect to Medicare eligibility, you could go to this website, www.ssa.gov, and if you're a railroad Medicare patient, then you would go to the secure.rrb.gov website on the internet, and you can find out where you stand. Okay, if you are a Medicare beneficiary, every year you're going to send Medicare is going to send you a little book, a handbook that says Medicare and You, to update you on your Medicare coverage choices, what your new deductibles are, and so on and so forth. And you can always download it as well on the Medicare.gov website. To be eligible for the premium-free Part A benefit, an individual has to be insured based on their own earnings or those of a spouse, parent, or child. So let's say, for example, you have a child with cerebral palsy, okay, and that child is on Social Security disability because of it. They become eligible under your eligibility as the parent, okay, and so be aware of that. So it's not just your own eligibility, it could be the earnings of a spouse. This is to protect women, for example, or even men who never worked outside of the home. They were homemakers all their lives. They relied solely on a single family income, and so a spouse would become eligible for Medicare under their husband's or their wife's eligibility, as long as they're still married. And there are some rules about that as well, as far as if you're married for a certain period of time, I believe it's 12 years, and your spouse passes away or you're divorced, you may still be eligible as a widow under a beneficiary. I don't know all the rules for that, but I'm sure it's something that you could find out if you needed to. To be insured, the worker must have a specific number of quarters of coverage, or QCs, which are 40 quarters. And if you need to know more about that eligibility, you can go to Medicare.gov and find out. The Medicare eligibility cards, when you become eligible for Medicare, you are given a red, white, and blue card. At this time, the red, white, and blue card, where it says Medicare claim number, is going to, if you are the beneficiary, if the Medicare eligibility is under yourself and not under a spouse, then, or a parent, then it's going to be your Social Security number followed by a letter. And generally the letter is a T for the temporary card, and then it goes to an A, B, or a D. And these, the way the Medicare numbers are utilized as it stands right now is actually going to be discontinued starting in 2018. It is called the Medicare Social Security Number Removal Initiative, so that by 2021 there will be no Social Security numbers on Medicare cards, and every Medicare patient is going to receive a new Medicare ID number. Okay, and so that's something that you're going to need to be watching for. If you're working in a doctor's office, you will want to, especially starting next year, because this is when they're going to be rolling out the initiative, new Medicare beneficiaries will not have their Social Security numbers on their cards, and the beneficiaries, the older beneficiaries, the ones that have had Medicare for years, are going to receive new cards, and if you try to bill under the old Medicare number, it will get denied. So from a billing standpoint, this is what you need to know about these red, white, and blue cards. Make sure that starting in 2018, you get new Medicare cards on all of your patients. Now, the way Medicare works is a Medicare Part C patient is still going to have a red, white, and blue card. And it's going to say Hospital Part A, Medical Part B. But it is not going to say MA Part C. The Medicare card does not indicate whether a patient has Medicare Part C. In order for a patient to have Medicare Part C, they first have to enroll in B, and then they can immediately enroll in C. It's very strange, but that's the way it works. And so all of their Medicare cards are going to say Part A and Part B, okay? So what you need to do is, if you have a patient that comes to you that has Medicare red, white, and blue card, and then another insurance card, and it says Medicare supplement, then that generally is going to mean they have original Medicare plus a Medigap. Or if it says Medicare Plan F, as in Frankfurter, if the supplemental card is a Plan F card, that generally means it's a Medigap. But what many patients don't understand is when they sign, and they really truly don't understand this, when they sign up for Medicare Part C, they no longer bill or have Medicare Part B, even though the card says so. And so Medicare Part C is it. So sometimes they will bring you their Medicare card and another card, and that card says Medicare Replacement on it. If it says Medicare Replacement or Medicare Advantage, that's a clue to you that that patient does not have Medicare Part B, and you're going to have to be very careful to find out where those claims need to go to, because you would not be sending it to the Part B MAC or administrative contractor if they have a Part C plan. You're going to be sending it to the insurance company that is carrying the coverage under that Medicare Part C plan. So you're just going to, so if they have Medicare Advantage, they'll have an additional insurance card supplied by the private company, but many times Medicare patients think that it's just a supplement. They don't understand that that is their primary insurance. So you need to be sure to be very diligent about that and look for that when you are verifying benefits or when you are intaking a new patient. Individuals who are entitled to premium-free Part A benefits are also eligible for Part B, which is the medical insurance. And since Part B is a voluntary program that requires the payment of a monthly premium, those individuals who don't want coverage can refuse enrollment but may incur penalties if they enroll in Part B later. So here's what happens. I do not recommend that a patient who is eligible for Medicare decline Part B. Number one, because you can't even look at Part C until you have enrolled in Part B. And number two is if you decide later on down the road that, you know what, I'm starting to need insurance more than I do now. Because, I mean, let's face it, you're 65 years old. You know, nowadays 65 is the new 50. Most people are really healthy at 65. You know, they generally have good health. Especially if you've been taking care of yourself and you eat right and don't run around with the wrong people and, you know, have a good dietary and don't smoke. And you may be extremely healthy and you may be looking at age 65 thinking, I don't really need Medicare, you know. So you decide to not enroll in Medicare Part B at that time. But 4 or 5 years later, you're starting to think, I think maybe I need Medicare now. What Medicare is going to do is when you decide you want to enroll, they are going to make you pay all the back premiums from the time you were eligible. So it's not worth it, okay? You really want to just go ahead and get enrolled in Medicare Part B when the time comes, when you turn 65 or become eligible under Social Security, and then decide if you would like to go with Medicare Advantage or Medicare or Original Medicare. Now, the same rule applies for Medicare Advantage. Let's say, for example, you choose Medicare Part B insurance, and you enroll in Medicare Part B, and then you decide right away, hey, I'm very healthy. I don't want to pay all of these premiums for supplemental coverage, for drug coverage. I'll just get a nice little Medicare Part C or Medicare Advantage plan with a low premium, and that will cover me in the event of something, you know, that something catastrophic happens. But then 2, 3, 4 years later, you develop some type of a chronic illness or your age begins to catch up with you and you begin to need more extensive health services, and you think maybe I should go back to Part B because the coverage is better. Medicare Part B is going to make you pay the difference between what you paid into Part C and what Part B would have cost for all of those years. So there's no way to get around it. You're either going to go with Part B, suck it up, and pay those Part B premiums, or you're going to make the choice to go with Part C, and once you do, you're pretty much stuck there unless you have that kind of money to be able to pay up all of those penalties to then convert yourself back to Part B. The same thing if you choose Part B and don't choose a supplemental insurance plan and you just want Part B. If later on down the road you want a Medicare Medigap policy, at that point in time you may have to pay a penalty of those premiums from the time you became eligible. So these are things to be aware of with respect to Medicare Part B and what your choices are. Now, individuals can enroll in Part B during the following enrollment periods. There's what's known of as an initial enrollment period, or the IEP. There's the GEP, which is the general enrollment period, and then there is the special enrollment period. So let's talk first about the initial enrollment period. It lasts for 7 months, and it starts 3 months before the month of eligibility, okay, and 4 months after. So from the when you turn 65, you don't have 7 months to choose. You actually only have 4 because your eligibility starts 3 months before the month of eligibility. Okay, so you need to understand that. Now, even though you choose your enrollment 3 months before, you won't be eligible until you're 65, but you can begin to make your choices and begin to shop around and decide the way you're going to go at least 3 months before the time of eligibility. There is a general enrollment period for individuals who refused Part B during that initial enrollment period. So let's say you decided, I'm not going to enroll at this point, and I'm going to wait until, let's say I'm going to wait until the end of the year, or your Part B coverage was terminated. you would go into the general enrollment period of January 1st to March 31st of each year, with your coverage becoming effective July 1st of that following year. So if you enroll under the general enrollment period, let's say you enroll January 1, you're still not going to be effective until July 1. Now you have special enrollment periods, and these are for situations where you maybe still work, okay, and you have a job, you have good benefits, and so you really don't need Medicare, and you don't really want to pay the Part B premiums for Medicare to be considered a secondary payer. Your insurance is fine, and you're going to work for 3, 4, 5 more years, and you've delayed enrolling because you or your spouse have had group health coverage based on employment. You can sign up for Part B with no penalty and no increased premium at any time, as long as you have the group health plan coverage based on current employment or within 8 months of the end of that coverage. So if you retire, let's say you become eligible for Medicare at 65, but you don't retire until 70. So for those 5 years, you can go without Medicare Part B. You'll have Medicare Part A because that's an automatic enrollment, but you don't have to choose Medicare Part B. You don't have to choose the drug plan or the supplement. And if you do choose Medicare during that period of time, Medicare will be a secondary payer. They will not be primary. Your company policy or your union policy will be primary, okay? These are things that as a biller you need to know, because patients, when you're billing out claims and Medicare says they are not the insured, that may mean that they are a secondary payer. It may mean that the patient has a Medicare Advantage plan, but you're going to need to know what the situation is with these different types of coverage scenarios. So individuals who have worked and are still working full-time and have benefits will not incur any type of penalty as long as you enroll in Medicare within 8 months of the end of the termination of the union health plan coverage. And you can enroll in Medicare during the time that you're employed, but again, that would be a secondary policy. Individuals who disenroll from a Medicare Advantage plan can return to original Medicare during the Medicare Advantage disenrollment period, which is January 1 through February 14, and we'll learn a little bit more about that when we discuss Medicare Advantage plans in Lesson 3. And so these are the Part B enrollment periods. Now that we have some information on Medicare Part A and B especially, we need to talk about providers and who is eligible to provide Medicare services. The Medicare program recognizes a broad range of providers and suppliers who furnish necessary services and supplies to meet the health care needs of people with Medicare. And the term provider is going to be used generically. So when they say provider, it could be a doctor, it could be a physical therapist, it could be a chiropractor, it could be a nurse practitioner, a clinical social worker, all of those entities according to this type of, according to this program are called providers. So we have beneficiaries, those are the patients. The providers are the doctors or the healthcare practitioners who render the services. So for a provider, they also need to decide how they want to participate in Medicare. Basically, most providers anyway have 3 choices. They can enroll as a participating provider in Original Medicare. They can enroll as a non-participating provider in Original Medicare, and I'll talk to you about the differences. And they can decide whether they want to apply to enroll in any of the Medicare Advantage plans. And one of the things that most doctors should do would be to go on to the Medicare website and pretend that you're going to be enrolling as a Medicare Advantage patient and pull up your zip code or your region of the country, and it will show all the Medicare Advantage plans that are operating in your area. and then you can decide, looking at the different benefits that are available and benefit structures, you can decide if you want to apply as a provider to enroll in those Medicare plans. Okay, so you need to decide if you're going to enroll. So the provider has the option to enroll as a participating provider in Original Medicare, as a non-participating provider in Original Medicare, or they can choose to opt out of Medicare altogether. A provider who opts out of Medicare will be able to inform Medicare patients that they do not participate at all in the Medicare program, and that if that patient wants to see them, then they would have to pay cash for their services. Now, generally, doctors who opt out of Medicare are doctors who are wanting to establish concierge practices or all cash practices. There are certain providers who are not allowed to opt out of Medicare. One of those are chiropractors. Chiropractors may not opt out of Medicare. They must either be a participating or non-participating provider. And if you are a participating provider with Medicare, essentially what that means is that your office would be responsible for billing that Medicare patient's services to Medicare, to your MAC or Medicare Administrative Contractor. And you would have those benefits assigned to you, which means the patient would, as a participating provider, the patient assigns those benefits over to you, meaning that Medicare pays you directly the portion that is covered under their Medicare policy, and then the patient would have to pay their 20% or their deductible. Or if they have a Medigap plan, then the Medigap would be billed or automatically billed by Medicare in many cases, and the Medigap would cover that 20%. So you have that option as a PARD provider. If you decide to enroll as a non-PARD provider, in that case, then you're still required to bill Medicare on behalf of your patients. It doesn't get you out of billing Medicare. You still are going to be required to bill Medicare on behalf of the patients. However, at that point in time, you can request that the Medicare patient pay for the services up front, do not accept assignment, and Medicare will pay the patient directly. And the patient is paid at a lower rate than if they go to a PARD provider. So the patient's out-of-pocket costs would be higher if they decide to seek care from a non-PARD Medicare provider. So those are the differences between the PAR, the non-PAR, and the opt-out. The opt-out is if a doctor opts out, they have to notify the patient up front before ever even seeing the patient that they are not enrolled in Medicare at all, and that the patient would have to pay cash, or they would let the patient know that they are non-PAR, and in that case the patient would pay for their services up front. Medicare would reimburse them, or if they're PAR, then the patient pays their coinsurance, their deductible amount if applicable, and then Medicare pays the provider. So those are your three differences. CMS is an agency of the United States Department of Health and Human Services. It oversees the Medicare program. They are headquartered in Baltimore, Maryland. Okay, and the Social Security Administration and the Railroad Medicare Board are also examples of other agencies involved in the administration of Medicare. CMS's mission is to ensure effective, up-to-date health care coverage and promote quality of care for people with Medicare. They establish the policy for the payment to the providers. They conduct research of healthcare management and treatment and assess the quality of healthcare facilities and services. CMS has regional offices throughout the nation, and has contractors who provide the billing services and the payment services for Medicare beneficiaries. So the contractor-provider relationship in CMS is such that that a provider will bill. You'll notice in this little circle, these four circles, you have providers, contractors, CMS, and organizations. And in this one, providers and contractors are not grayed out, CMS is. What that means is that as a provider, you do not bill services you do not bill for the patient's services directly to Medicare. You're going to bill for the services to the contractor, to the Medicare administrative contractor. And there are different types of contractors. You have the MACs, which administer the Part A and B services, the MA plan contractors, which are your Part C or Medicare replacement, and your Medicare prescription drug contractors. Many organizations will work with CMS to administer the Medicare program, and they're located throughout the country. Some organizations primarily work with the providers, while others will work with Medicare beneficiaries. And if you go to the job aid, kind of takes you to an info sheet about the different benefits about the different organizations. For example, the Benefit Coordinator and Recovery Center, Comprehensive Error Rate Testing Contractors, the Office of the Inspector General, and so on and so forth. So, oh, come on, I should be able to go back, I hope. Let me just, hang on a second. Will it allow me to? I guess. I didn't mean to do that. Hold on. Okay, so I got to resume here. Hopefully it'll take me back. Stay on page. Stay on page. There we are. Okay, we're back. So anyway, the job aid will tell you more about the organizations that help patients and also work with providers to make sure that the Medicare services are being billed in the most efficient way possible. We'll be talking about audits and so on and so forth quite a bit in our compliance class, so I'm not going to spend a lot of time on that. Medicare educational resources are available on the CMS website to assist providers in learning more about the Medicare program, and it is important that you stay informed as to Medicare updates. There are updates taking place all the time. New healthcare policy revisions, legislation, and these could change how you bill Medicare and how you treat your patients, how you collect from your patients, and so on and so forth. So it's very important to know how these Medicare programs work and stay up to date with the Medicare programs. All right, so we're going to take a little quiz, and you all can sort of do this mentally. You don't have to fill it out or anything, but just so that you have in your mind, you know that your knowledge base on this is fairly good. So let's talk about these Medicare essentials from lesson 1. So select true or false. The Medicare program serves the aged, certain disabled individuals, and individuals of any age who have been determined to have end-stage renal disease. And what I'm going to do is right now I'm pulling everybody off of mute. I can get everybody off mute. And so what do you think? Is it true or false?
True.
And everybody said true. You are correct. All right. The Railroad Retirement Board oversees the entire Medicare program.
False.
False.
Okay, who oversees the Medicare program?
Good.
CMS, Center for Medicare and Medicaid Services. Medicare beneficiaries can receive their Medicare benefits, Part A and B, through the original Medicare plan or through a Medicare Advantage plan. True or false?
Oh, Medicare plan.
Don't be shy.
True.
Okay, true. Medicare Part A is also known as, which one?
Hospital. C.
Hospital insurance. Correct. Choose the type of care that is not covered by Medicare Part B.
Okay. D.
Inpatient hospital facility services.
Wait a minute.
That is correct. That's covered by Part A. All right, super duper, guys. All right, it's 7:20 right now. We're going to take a little 10-minute break, and then we're going to finish up with lesson 2 and 3, and then move on to our next segment. So I'm going to go ahead and stop the recording. All right, now that we've concluded this part of the webinar, let's move on. And I don't know if you all received an email from me earlier today, but I did send you a new handout, and this is on coding basics. Now, I know that many of you have just taken 21 hours of coding with me. Okay, this is coding, but it's going to be a little bit different. And so while some of this is going to be a review for some of you, what we really need to do is take what we learned in coding and apply it now to what we do as medical billers. And so we're going to go through just some basic information about coding, and we're going to show you now how the codes are structured within the framework of a claim, and how they're structured within the framework of of different services. So I'm going to go ahead and mute you all again, just so that we don't have a lot of background noise, and let's go ahead and get started. So in order for us to run a successful billing office, we as the billers need to understand how to speak in the correct language, and that's the language of insurance. And the language of insurance is all done in code. You have codes for charges and for the services that are being provided at the doctor's office, which are your CPT or your HCPC codes, codes for conditions or illnesses, ICD-9, not anymore, but ICD-10 codes, and codes for additional clarification or detail about a particular encounter, and those would be called the modifiers. And then the important thing is how we put this all together. Here's a few things that you need to remember about coding, and I'm sure if you were in the class, if you've taken the coding portion of this boot camp and you bought the coding books, you know that you will never learn all of them. I mean, the ICD-10 code book itself is comprised of 71,000 codes, and the CPT code book has thousands and thousands of codes. But what probably is going to happen with you now as you move out of the realm of just taking a general coding class is you're going to go and work for a doctor, and that doctor is going to specialize. Maybe there'll be a family practice doctor, but more than likely you're going to be working for a doctor who is a chiropractor, a dermatologist, podiatry, family practice, neurology. And when that happens, you will become familiar with the codes of the medical discipline that you're working on the job as you go. And over time, those codes will become very, very familiar to you, and you'll be able to pull them right out of thin air. So, one of the things that you need to understand is that there are going to be a lot of books and software and web-based programs that will also help you in finding codes. And the main thing to learn about coding is what the functions of the codes are, how to find the appropriate code, and then put them all together to form a language pattern that insurance companies will understand. Now, when you took the coding class earlier this last month, a lot of what we learned was how to find the appropriate codes, how to extract verbiage out of a doctor's note to look for the correct code to bill. But now we have to know how to put all of those codes together in order to create a claim and create language that the insurance companies are going to understand. So let's just do a quick review of the different types of codes that are out there. We have the service and procedure codes, and the two code sets that you're going to be working out of are going to be the CPT code book, which is the current, which stands for current procedural terminology, and CPT is really going to be the first place that you go to look for an appropriate service code. There are some exceptions. There are other code sets such as home health billing. Those are called HIPS codes. Durable medical equipment, which are HCPC codes. Dental CDT codes. The majority of the codes that you're going to be working with under CPT are going to be 5 numeric digits, and they'll look something like the ones that are shown on your screen now: 99202, 72020, 97110, and so on and so forth. The other code set that you may find yourself coding out of from time to time would be the HCPCS code set, and HCPCS stands for Healthcare Common Procedure Coding System. The CPT code set is developed and maintained by the American Medical Association, and the HCPCS code set is developed and maintained by CMS, or Center for Medicare Services. Mainly, the HCPCS codes are going to be descriptions of supplies and services requiring supplies, such as oxygen, wheelchairs, canes, orthotics, taping, strapping, supports, etc. And the majority of HCPCS codes are 5-digit codes, beginning with a letter and followed by 4 numeric digits, such as the ones you see here, like A9150, E0210, L3020, and so on and so forth. And so those are the two service code sets that you would generally be working out of. The CPT codes, the Category 1 CPT codes, and there are 3 categories, but the ones that you'll be dealing with most are going to be the Category 1s. Those are 5 numeric digits. And the types of services are grouped by their first and second digits. Understanding this will help you find the codes easier. So the first digit will pinpoint the type of specialty. So every code that starts with a number 7 applies to radiology. Okay, and so it could be diagnostic imaging, X-ray, CT, MRI, and so on and so forth. The second digit applies to the anatomical region. So all radiology codes of the head and neck are 70,000 series codes. Radiology codes that start with a 1 are chest codes. 72,000 codes are spine and pelvis, and so on and so forth. And all other specialties and CPT codes are grouped and coded similarly. One of the most common of the service procedure codes that you're going to be dealing with in medicine are the evaluation and management codes. And these are the codes that represent outpatient office visits, examinations, office visits, and consultations. In the new patient outpatient office visit code, which are the codes 99201 through 99205, you will know that you're dealing with a new patient by the indicator of the 4th digit. So if the 4th digit starts with a letter 0, a number 0, then you're dealing with a new patient. If the 4th digit is a 1, then it's an established patient. And the 5th digit will indicate the level of service, from a minor service to a comprehensive service. Your CPT coding books or software will help you determine which code to use based on the doctor's notes and their documentation of that service, how much time was spent, the severity of the problem, the level of history, the complexity of the exam and medical decision making, as well as the overall time spent on the encounter. As a coder, your doctor's notes and exam charts, as well as the patient history, would help you determine which code to use. And we did some extensive work during our coding boot camp on how to choose levels of E&M codes. As a biller, you may or may not have a lot to do with that. What you're going to find on the billing side of things is that the provider will already tell you what code to bill. It's just going to be you putting it into a format, i.e. a claim, that the insurance carrier will understand. However, with that said, as a biller, it is going to be your responsibility to check and spot check your physician's documentation to make sure that the documentation that they have supplied supports the code that they're giving you, because that documentation is like the receipt. And there's going to come a time here in the next several years, we're not exactly sure the exact date that this is going to happen, but it is coming, to where the documentation is going to have to accompany a claim. And so doctors are really charged with making sure that their documentation is an exact mirror of the code that they're submitting for billing, so that they don't end up having money taken back on audit, or worse yet, being accused of fraudulent billing. The HCPCS code set are the 5 alphanumeric codes, and these are generally used to describe supplies and DME. DME stands for durable medical equipment. Types of services are generally grouped by the alpha prefix, so understanding this will help you find codes easier. So all of the A prefix codes are your supplies, things like tape and splints, oxygen supplies, tubing, incontinence supplies, shoe supplies for diabetics, and so on and so forth. The E prefix are DME, durable medical equipment, are going to be things like the canes and crutches and walkers and wheelchairs and heat lamps, hospital beds, and so on. And then the L prefix would be your orthotic devices. Those are going to be your cervical collars, your rib belts, back supports, orthopedic shoes, inserts, ankle foot orthoses, and so on and so forth. And so that the L prefix is going to deal more with that. And then each one is slightly different and is going to deal with a different area of durable medical equipment. Other code sets within the HCPCS code book is you do have HCPCS procedure or assessment codes. These are used to describe procedures, assessments, measurements, and injections. And so if you, for example, the J codes are your injectables, and it's not the administration of the injection, but the type of medicine that is being injected. So, for example, J3420 is injection B12. So that is the B12 injectable material that is being injected. And then there is a code for the administration of the injection, but that's a CPT code. The HCPCS private payer codes, these are temporary codes used by Blue Cross and other private payers. These generally start with the letter S, and these are going to be codes that are assigned before CMS fully and the AMA fully vets a certain procedure. And while they're in the vetting process, while the technology or the procedure is being cleared by the FDA, the Federal Drug Administration, while it's going through clinical trials, they may be awarded a private payer code so that private payers can pay for it even before Medicare does. And then you have the temporary level 3 HCPCS codes, which are transition codes for experimental services. They usually start with the letter K and Q or end with the letter T. but you won't use those very much. Now, you'll notice that on this slide, I have a book that has a big X through it, and you'll notice that that book has a 2011 on it. And here's what I need to tell you about the CPT code books, about these books that you're going to get to use as a coder or even as a biller. Codes change rapidly. Every year there are going to be anywhere from 400 to 500 to literally thousands of code changes in your books. And so it is not a good idea to have a 6-year-old code book on your desk when you're trying to code in 2017. So my recommendation is that your code book should never be more than 2 years old, okay? And every year, for your particular medical specialty, you need to have an updated code set. So for example, if you're going to be billing chiropractic, you may have a full CPT code book for every CPT code in the universe, but you only use a select number of them for chiropractic services. Use the chiropractic manipulation codes and the physical therapy codes, physical modalities, some exam codes. You may use 25 or 30 of the thousands of CPT codes. What you would want to do is you would want to have a CPT code book, and then if you don't purchase a new CPT code book, then go to the American Chiropractic Association or go to a specialty coding source like Chiro Code, for example, and get a new code book for the specialty codes that you use, or at least find out which codes have been deleted and which new codes have been added. This year in chiropractic, we had a fairly significant code change in X-ray, in the thoracic X-rays, and so you know, doctors kept billing the old thoracic X-ray codes and were getting them denied and didn't know why. It's because they were deleted out of the 2016 code book. After 2016, they were no longer valid. You couldn't use them in 2017, and so unless you have a new book or keep up with the books, you've got to make sure you do so as a biller so you're avoiding claims being billed erroneously. Now, diagnosis codes are the piece of the coding language that give carriers the reason for the medical encounter. Every claim that is paid by an insurance company is paid based on whether that claim is considered to be medically necessary, and the diagnosis codes are what establish medical necessary. The burden of proof is on the healthcare provider to show the insurance company that the claim is medically necessary, and they do this by placing a diagnosis code or a series of diagnosis codes on the claim form. The diagnosis code set that is currently being used is the ICD-10 CM code set, and it stands for International Classification of Diseases 10th Revision Clinical Modifications, for CM. This was a coding set that originated in 17th century England and was taken over by the World Health Organization and used. This is an international code set. It's not just used in the United States. It is now used worldwide by the World Health Organization to track and chronicle diseases and causes of death, mortality, to track epidemics, and so on and so forth. In 1988, it was mandated by CMS to be used on all Medicare claims. So before 1988, you did not have to use a code, a diagnosis code, on a claim form. I remember that because I started billing in 1982. And so for a number of years, the only thing you had to put on a claim form as far as medical necessity was what did the patient have, and there was a box where you would write in flu, stomach virus, sore throat, fever, and that would be what would go on a claim form. But in 1988, the ICD code set was adopted as the standard for coding, and at that time, the ICD-9 code set was the was the revised, the most current revision. The ICD-10 code set was adopted as of October 1st, 2015. So from 1988 all the way through 2015, the ICD-9 code set was in use. And then on October 1st, 2015, Medicare changed to the ICD-10 and other insurance carriers. They also followed suit. ICD-10 in the United States is maintained by the National Health Center for Health Statistics and the Centers for Disease Control. The ICD-10 codes are 3 to 7 numeric or alphanumeric digits. They're 3 digits followed by a period and then up to 4 more digits. The numeric sequences give clues to anatomical systems, and the complete numeric list has 21 chapters and over 71,000 codes. And there is enough expansion in the code set available to take it up to about 105,000 codes. So that's what the ICD-10 codes do as far as the piece of the puzzle as it stands for billing out claims. The CPT codes tell you what happened. The ICD-10 codes tell you why it happened. And the modifiers give insurance carriers more detailed information about a patient encounter, and I call these the "oh, and by the way" codes, and meaning, oh, and by the way, there's something else we need to let you know about this particular encounter. It gives information about the need for multiple codes, additional time, maybe multiple healthcare practitioners saw the patient in one visit. It helps an insurance company understand why certain codes were used concurrently or together. Some modifiers will result in an altering in reimbursement, and some are for informational purposes only and don't affect reimbursement. Modifiers will give more clarity to DME billing. So, for example, if you're billing out foot orthotics or foot inserts, you're going to bill 2 units, one for the right side and one for the left side. And if you don't use those RT and LT modifiers, your claim may be denied, because if you bill 2 units, they'll think that one is a duplicate of the other, unless you should say, oh, by the way, one of them was for the right foot and one of them was for the left foot. Modifiers are used to combat CCI edits, and I'll be talking quite a bit about CCI edits during this billing boot camp. Modifiers are 2 digits. They can be either all numeric, all alpha, or alphanumeric. The use of multiple modifiers on a claim is not uncommon, and up to 4 modifiers can be used on any service line or any service date. Most CPT coding books will have a complete list of the CPT modifiers. The HCPC coding books will have the HCPC modifiers. The CPT modifiers are all numeric, and the HCPC modifiers are alpha or alphanumeric. And you can purchase cheat sheets. This one is you can get from the AMA bookstore for about $22, and it has level 1 and level 2 modifiers that shows you what the different modifiers are and what they're available and so on and so forth. These are just some common modifiers that you might run into as a biller. The 25 modifier is one of the most common ones. This is where a patient has an examination and a procedure on the same day. We place the 25 modifier on the exam code in order to let the insurance carrier know, oh, by the way, we examined the patient, but we also performed a completely separate procedure, such as whirlpool therapy. Bilateral procedure is if a patient has a procedure on 2 sides of the body. So, for example, they had both of their wrists strapped. They fell, and when they fell, they placed both their hands down, and so as a result, they strained both of their wrists. And so the doctor tapes up their wrist and bills for that strapping code, and oh, by the way, we did it on both, a bilateral procedure. Reduced service means that the patient has come in for a service that is normally a code based on time, and but they didn't use the full amount of time, and so basically they're going to code for a reduced amount of time using the 52 modifier. Now that's a modifier that would affect pricing, because when the insurance company sees that, they see that the patient came in for 20 minutes, one unit is 15, what do we do with the other 5 minutes? We add another unit, but then add the 52 modifier to it. A distinct procedural service means that there were 2 services that are very similar in description but very distinct from each other, and and so you bill both of the services, but then you have to add the 59 modifier to indicate that the service was distinctly different than the other one, and so on and so forth. I'm not going to go through every single one of them. These are just some examples of modifiers that as a biller you may run into, and modifiers that you will need to know for your particular, you're going to need to know these modifiers for your particular medical specialty, because if you fail to use a modifier, a claim could get denied and then you'd have to reopen it. So we have the CPT codes, we have the fees, what those service codes are worth. We have the ICD-10 codes, which is why a service was performed, the medical necessity part of it. And then we have the modifiers, which are, oh, by the way, there's something else we need to let you know. And all of those codes, all of that code forms the alphabet of insurance. So the next step to that is to take those components and form a language pattern that the insurance companies will understand. And so we're going to end the class with just this little case study, and then we'll be done. And so let's just talk about this. Here's a case study. The patient goes to their podiatrist complaining of foot, knee, and back pain. The podiatrist determines that the reason for this pain is due to the patient having flat feet. The doctor prescribes custom-made orthopedic insoles for both feet to create an artificial arch, thereby relieving the patient of pain and preventing degeneration of joints and stress on the back. Okay, so that was what was in the case notes and in the case study. So how do we code that? So first thing we have to do is find the CPT code. What was done? How much was it worth? Why was this medically necessary? And were there any modifying or extenuating circumstances? Oh, and by the way. So an insurance claim in sentence form would be, the CPT code would be L3500, orthopedic insoles, which is the code for orthopedic insoles, were billed for $50 each, because the patient has M21.40, that's the ICD-10 code for flat feet. And by the way, we billed 2 units, one for the LT modifier, left foot, and one for the RT modifier. So that's how that would look in that's how it would translate out to a sentence. But all you would see on the claim form is this. Okay, it wouldn't have any of the words. It would just have L3500, LT, M2140, $50. L3500, RT, M2140, $50. And that's all the insurance company needs to see on the claim form. Of course, it would be placed into the appropriate field or the appropriate box on the claim form, and they would see that, and that would be paid correctly because it tells the insurance company in code the correct story of that patient encounter. But what if it's not coded correctly? What if they coded L3500 and then L3500 again, used the diagnosis code M62.81 and coded it for $200? So basically, in this case, they said that L3500, which is orthopedic insoles, were billed for $200 each because the patient has M62.81 muscle weakness. 2 units were billed. it just wouldn't fly. The insurance carrier, first of all, would look at both of those codes because there's no modifier. They would think it was a duplicate. They wouldn't see the RT and the LT. So that's the first problem. The second problem is that muscle weakness, generalized muscle weakness, is not a diagnosis that would justify the need for orthopedic insoles. And then the final thing is that $200 a piece is way too expensive. And so that claim would more than likely be denied. Okay, we are actually done. We've completed our lesson for the day. Next week, we're going to be doing a billing practicum, and this is when I'm going to go through the insurance billing rules and how we put the claims together, the life of a claim, how it gets started, how it gets finished. We're going to look at things like reading EOBs, interpreting EOBs, understanding claims denials, and we're really going to get into the meat and potatoes of it. Now, with that said, because of the July 4th holiday, there will be no live webinar. What I'm going to do is I'm going to pre-record the 6 hours sometime next week, and then I will make those recordings available to you, and I'll send you the YouTube links so that you can upload them directly or download them from YouTube or listen to them directly. So the only thing that really is going to be missing from it is the question and answer period, but what I've found with these webinars is that most everybody is too shy to ask questions anyway, so we'll just go ahead and tape those webinars, and then you can listen to them at your leisure, on your own time. But we're not going to have a scheduled time where we're all going to meet together because of the holiday. So everybody, thank you again so much for taking time out of your busy schedules to listen and to learn. I do appreciate it. You have no idea. I know some of you are listening in who are some of my billers who are just listening in to get better trained and to refresh yourselves a little bit, and I that does not go unnoticed. I really appreciate that. For those of you who are in the boot camp, again, I appreciate you being here tonight, and I wish you all the best. If I don't get a chance to speak to you before the holiday, have a safe 4th of July holiday, and we will be talking to you again soon. Thanks, everyone.
Thank you, Lisa.